Okay, so I think that we can start. I have the pleasure to chair this second webinar of the series on COVID and endocrine diseases that we started the last Thursday, speaking with Manel Puig about diabetes. Today we have another fantastic topic and another fantastic speaker. We will have the webinar on obesity and COVID, and the speaker will be Professor Bulent Yildiz, who is chair of endocrinology in Hacettepe University in Turkey. Bulent is our treasurer in the society, has been among the officers. We closed collaborated during these years. He is a very, very enthusiastic and careful person to all the development in the science and the clinical scenario that we are facing. And for sure, COVID is one of the real things that in the last months was of paramount importance for everybody of us. So please remember to write your question in the question and answer section, and I will ask that many questions that I can at the end of Professor Yildiz's presentation. Thank you very much for joining us from more than 70 countries in the world. I think that these webinars are already a huge success, and after today will be even more. So thank you, Bulent, for joining us, and the floor to viewers, obesity and COVID. Thank you very much.
Thank you, Andrea. So good afternoon to everybody. So today we will be overviewing COVID and obesity. I want to first start with the data from our recent Congress showing that diabetes, obesity, and metabolism is at the heart of the society. You see, they have one of the highest submitted abstracts. And if we look at the workload of the endocrinologists in Europe, we see that diabetes, obesity, and metabolism is a very significant and important part of it. So that's why the second seminar is about obesity and COVID. The outline of this talk would be, first, I will overview the potential pathophysiological mechanisms linking the two disorders. Then we will look at the clinical data. And then we will touch upon challenges in the management of obese patients with COVID-19. Then coronavirus pandemic public health measures and how do they affect obesity. And finally, we will conclude with some future perspectives. So we already know that obesity is associated with an increased infection risk. So men and women have different risk for certain infections, but obese people are predisposed to have more common infections due to several reasons we will go over. And in fact, since this is a viral infection, if we go back and check the influenza data, this is data from California showing us that people with influenza who were hospitalized, you see the case fatality ratios. And when you have a BMI over 45, so this is class 3 extreme obesity, then your fatality rate is about 34%, and it's significantly higher than the other groups. What is the mechanism of viral pathogenesis for COVID? So far, we already know the details, but the virus is getting into the cell using the ACE2 receptor, and then it leads to downregulation of this receptor. And then the clinical stage starts with a viral response phase first, then we have an inflammatory stage, and then you have starting from a pneumonia coming to a systemic inflammatory disorder. And if we look at the clinical manifestations of this viral disorder, we see it affects several tissues and organs. So pulmonary effects is most significant, but we have effects everywhere in the body. And what is relevant to today's talk is adipose tissue is also important, because when you look at the different tissues in the body, you see this ACE receptor is expressed in several tissues, including the adipose one. In fact, there are now discussions whether it could serve as a reservoir, but so far we don't have any direct evidence. And if obesity has an effect on COVID-19, how this could happen? And here you see in an obese individual who has excess fat, adiposity, you see you have pulmonary problems, you have cardiometabolic problems, you have immune hyperreactivity, and you have dysregulated inflammatory response, which might also associate it with increased viral shedding and increased viral load in breath. We are talking theoretically at this point. And these all could lead to increased severity of the COVID infection in these obese individuals. And there might be a vicious circle. So once you have this SARS-CoV-2 virus that enters the body through the respiratory system, when it reaches to other organs within the adipose tissue, it might stay due to increased expression of these ACE2 receptors. And then you have the activation of the immune system, increased synthesis and secretion of these cytokines. And then this could result in a more severe clinical phenotype of the infection. But these are all theoretical aspects. But how about when we look at the data, the clinical data? This is the website I'm sure you all know very well, which gets more than 1 billion hits every day, which shows us that as of today, we have over 5 million cases of COVID. And look at the number of the countries here with the highest cases, starting with United States. Then if you look at the obesity map, we have over 650 million people, obese people living in the world. And if you look at these countries you have seen in the COVID map, they also have quite increased prevalence of obesity compared to the average of 13%. So the top 10 countries you see here who have the highest rates of COVID-19, but at the same time, quite high rates of obesity. So are they interrelated? Then of course you wonder, you would get some data from the big studies. So here you see the studies published in the last 4 months from the very important general medicine and general science journals. So you have Lancet, you see the citations in 3 months reaching almost to 5,000. You have New England Journal paper from China. You have 2 JAMA papers. And just yesterday, we have the China paper published in Nature. And you see all the titles show characteristics, baseline clinical features. And you wonder if you could get some information about adiposity. And the answer is no. So none of these studies are giving us any information about the BMI or adiposity of these patients. You have historical data regarding comorbidities. And for the last paper, you have wonderful data regarding variability of the virus, several lab parameters, but not the BMI or any marker of adiposity. But then we need to look at the studies that gives us this kind of information. Most of them are coming from US. So the first question that I would ask is obesity more common in patients with COVID-19? You see 5 studies, all of them published from US. And when you look at one number, it's also very important to have a benchmark to make any comment. And here you see the general population obesity prevalence in the US. So you see some of the studies have, including the largest one, the CDC report, tells us that the obesity is high in COVID patients. But if you look at some other studies, it's not very different than the general prevalence of obesity. Then the second question is obesity more common in hospitalized patients with COVID-19? And here we see the data from 3 studies. And then again, we keep in mind that the general prevalence rates, and here you see all of them tells us that those who were admitted to the hospital have higher BMI compared to outpatients, compared to those who were not admitted. The other question I'm going to ask is obesity more common in hospitalized patients, looking at worldwide? And here you see all the reports available to us. The worldwide prevalence of obesity, we said 13%. So if we look at this large report, ICERIC report, including more than 17,000 individuals, the prevalence of obesity in COVID patients is very much the same with the general prevalence in the world. If you look at the US data, again, some are giving a little higher, some are giving lower, but the higher the number of individuals you include in the study, in other words, the larger the study, the closer the prevalence rate you are reporting to the general prevalence. But when we go to Europe, we have a data from Germany, again, a small study, but showing us the hospitalized patients have almost 70% higher prevalence rates of obesity compared to general population. And if we look at China, one study tells us the prevalence is similar, other one says it's more than doubled. Then we are in the hospital. The next question I'm asking, is obesity more common in ICU patients with COVID-19? And in these studies, again, of course, putting the background obesity rates, these studies are consistent. Even though the differences are not the same, almost all of them are telling us that the critical patients who were admitted to ICU are more obese than the non-critical patients who are in the floors. Then what other factors could affect obesity? Again, if we go back to this large CDC data set, what we see here is the younger patients are more obese. And in fact, another study from New York City looking at the correlation of the BMI and age clearly shows us that the more obese patients presented to the clinic are younger. So obesity seems to be associated with age in the context of COVID-19 when the patients present to the hospitals. Then, is obesity a risk factor for everyone? So this study includes both outpatient and hospitalized, and they make a stratification, illness severity based on different categories. So here we look at younger and older. We see, as we have said already, the younger patients are more obese. But when you divide the group with non-obese versus obese, you see for obese individuals who have hypertension, they seem to have better outcome compared to the others. So it's a confusing data for the association of hypertension and obesity. Then a very important point that we don't have data much, but we definitely need, and that's the health disparities in this context. So this slide tells us the clinical outcomes stratified by race. And if you pay attention to the yellow bars, you see the African Americans, represented by the yellow bars, have more obese people. I mean, they are more represented in patients that are hospitalized, in patients that were accepted to ICU, and patients intubated. So at this point, we don't know whether it's simply related to higher prevalence of obesity, diabetes, and other comorbidities, or some genetic factor predisposing these individuals. We definitely need more data in this context. And if we look at a single center experience from Turkey, that I just want to emphasize the background population and where you work is important. This is the retrospective evaluation of medical records. You see only half of them providing data for BMI. But when we look at whatever data available to us for BMI, we see the overweight or obesity are not significantly different or higher than general population in either hospitalized or patients admitted to ICU or patients deceased. And in fact, if you look at further to this small set, you see age is significantly important. In fact, the ones who lost their lives were almost all of them were over 65, only one below 65. But again, if we look at in the context of age, we see not much difference for normal overweight or obese. So different from the US data, from my own country, I cannot tell that obesity differs in different ages in COVID patients that are hospitalized. But then there is this data set that I got it by personal communication. We have 17 ICU centers at this point collecting their data. They have one of 105 confirmed PCR confirmed cases. Here you see the comorbidities, and similar to what we have from the world, the highest one being hypertension, and then diabetes and cardiovascular disease. But what is important for us for today's talk is if you look at the BMI groups, yes, the total women and men are different. Women are more obese, but then it doesn't mean anything for the outcome of the study at this point. Now we go to France. Since the beginning, within the last 3 months, 2 groups from France are publishing about COVID. And in fact, just yesterday, they had one combined data set published that I didn't put it here, but it's pretty much too similar what they have in these 2 separate studies. These studies tells us that if you look at the ICU patients, they are more obese. The COVID patients are more obese than the non-COVID. They need more mechanical ventilation, and the higher the BMI, then the higher the need for mechanical ventilation. Lille and Lyon are not exactly the same for absolute numbers, but the trends are exactly the same. So the obese are more admitted to ICU, the obese are in more need of mechanical ventilation. This is a big consortium collecting data from several parts of the world, and this data represents 35 countries. So they have over 20,000 hospitalized patients and over 17,000 have BMI values. You see, as the age increases, so does the BMI. And within that data set, similar to what we have from several others, age is very strong predictor, but at the same time, obesity also appears to increase the risk in these patients. Now we go to UK, NHS data. They look at electronic health records of 17 million people, and they have 5,600 deaths from that data. Again, age is separately very important, but if you look at obesity, as the class of obesity increases, so does the risk of death in COVID patients. This is another report from, again, looking at electronic medical records from UK and Wales and Northern Ireland. So you have the BMI recorded in 6,000 patients. And if you look at the total prevalence of obesity for the ICU patients, 38.5%, and it's not very different from historically controlled controls that were in the ICU due to other reasons, or the population data. And more importantly, you see the BMI distribution is similar in the patients who required advanced care. And I think the most impressive part of this data, if you believe, is here. So here you see the discharged alive patients from the critical care versus those who died in the critical care. And you see the BMIs between 30 to 40 and over 40, the prevalences are almost half and half. So this data tells us the obesity is not important for the outcome, and based on 6,000 patients' records. But the best one I would say about this, I mean, among these studies came just 2 days ago. Why it's a good study, even though the numbers are not very high. This is from New York as well, but this is prospective data collection. Most of the studies you will see shorter follow-up. This one has almost a month, and the data is near complete. The obesity rate is about 46%, 13% being morbidly obese. But the main message here in this slide is the BMI over 40, morbid obesity, is not associated with hospital mortality in the setting of a New York hospital. Then, of course, you know, obesity and diabetes are twin diseases, so they go together. In fact, 85% of patients with diabetes have obesity as well. And this is a very big study. The preprint is available now. This is from France, called Coronado study. The primary outcome here, you see intubation plus death within the 7 quite short days of admission. And for today's talk, if we focus on BMI, one standard deviation increase in BMI is increasing the risk for the primary outcome 24%. And in fact, if you do the stepwise selection with age and sex forced, you see age and sex do not come out significant, but obesity is still significant. So in the setting of diabetes, BMI seems to be linked to the outcome of the patients with COVID-19. Then everybody asks a question, of course, about the drugs that patients with diabetes or obesity are using. And, for obesity, we have the GLP-1. So the question is, when you have GLP-1, this is a cell culture study. In a cell culture study, we know this GLP-1 analog, liraglutide, reduces oxidative stress and inflammation in endothelial cells. So then one could ask whether it would be helpful in the setting of COVID. But the indirect data from Coronado study, that is on patients with diabetes, showing us that the GLP-1 receptor agonist use doesn't make a difference for the primary outcome. So in other words, for clinical standpoint, we don't have an answer whether GLP-1 would be favorable or not. Then, having said that, it's obvious that the data are not all the same direction. So we have some challenges for the interpretation. Most of them are retrospective chart reviews, a few of them cross-sectional, and very few are short-term observational. We have the missing data issue. So the BMI data are either anecdotal or not collected in a systematic way. Several confounding factors. You look at the obese patients, but every obese is not the same. So we don't have the information for other comorbidities. And more importantly, we have differences in background population characteristics. So one study from one population cannot easily be extrapolated to the other population. And if you look at the variations of reporting methods, if you look at what kind of outcome parameters investigators are putting, you would see there are several things. And if you look at the treatment protocols, they are not the same. And in fact, a study from January is very much different from a study in April, because the treatment protocols, the standardized ones, are also changing continuously. And we, of course, have unidentified factors. What's going on for the research in the field? So here you see the current studies. If you just go to clinicaltrials.gov, there are 25 studies at this point that are about obesity and COVID-19, and we look forward to the results of those studies as well. Then we come to the real world. What kind of challenges we have for the management of obese patients with COVID-19? We know that obese patients have difficulty for transportation. We have difficulties in venous access. Many hospitals have limited number of bariatric beds that are different in different parts of the world, but that's a reality for most. We have imaging problems, and chest CT become very important, but when you have morbidly obese patients, it is difficult to have high quality images or even fit the patient into the machine. And when it comes to intubation in the ICU, the airway management is not as easy as a lean patient with COVID. And finally, we learned that positioning, the prone position, is very important. But when it comes to obese patients, especially severe obesity, positioning is also a challenge for ICU team as well. Then another issue is the nutrition. We know from the literature that for obese individuals, usually the nutrition initiation is delayed. And for the COVID patients, I can tell you that finally, in the last week, we have this guideline came from ESPEN. So we now have a guideline that tells us what to do, both for infected outpatients or in the hospital, but also for patients who are in the ICU. And just to summarize these suggestions, including the ones from the European Society of Endocrinology's statement, we prefer oral or enteral nutrition if possible. We need to estimate the daily calorie need, and usually it's about 25 to 30. They have increased demand. And for obese patients, the protein intake is important. It should be about 1.5 grams per kilogram. Supplementation of vitamin D, very hot topic, a topic for the next ESE webinar and a topic for our president, but there are ongoing studies. Replacement of micronutrient deficiencies, and of course, maintaining of glycemic control, both in patients previously diagnosed with diabetes and who have hospital hyperglycemia. So we need to be vigilant for other comorbidities. Then there is this issue of immunization. So far, we don't have a vaccine, and probably for at least a year, we would not have one. But if we have a vaccine, based on the experience we have from other viral infections, influenza being one, we know that both pre-exposure innate response, cellular response, and long-term immune response all are altered in obese individuals. So a vaccine that is developed for SARS-CoV-2 might not be as effective as in lean individuals when it's used in obese individuals. So immunization would be an issue in the future for obese people. And then there is this issue of surgery for both severe obesity and severe patients with diabetes. What I could tell without getting into details is there is a guideline from the DSS group now, very recently published, telling us which patient to have the obesity surgery right away, which patient to postpone, and what to do perioperatively for these patients at the time of COVID era. Then we are looking at the coronavirus pandemic public health measures. And when we say public health measures, that's the reason we are having this webinar and we're not getting together physically. So this quarantine and isolation and lockdown, they are very much related to anxiety and stress, and they reduce the outside exercise. They increase eating and drinking just to feel better, emotional eating. So the outcome could be highly relevant for obesity. And in fact, if you look at the social media with this hashtag quarantine15, meaning that getting 15 pounds during this lockdown, hundreds of people are discussing these topics. But looking at the studies, two studies, one from Verona, small study for a longitudinal one on children, telling us that at the time of lockdown, the number of meals, the consumption of junk food is increased, screen time is increased, sleeping time is increased, and consumption of vegetables and fruits decreased, but not significantly in this study, and the physical activity is decreased as well. There is one survey, this is the only one I could come up with. This is an online survey that was performed on individuals from France and Switzerland. And what it tells us is that the physical activity is decreased during these times. And you see the sedentary behaviors are inversely correlated with both mental health and physical health. So both adults and children are moving less and eating more junk food nowadays, and we need to be careful about the outcome of this health behavior. So based on what is available to us, how should we conclude? Obese people in general are more susceptible to viral infections with poorer outcome. Pulmonary, cardiometabolic, immune, inflammatory, and thrombotic mechanisms are linking adiposity and COVID-19. Obesity appears to be more common in COVID-19, but particularly if you look at most of the studies in younger patients and those admitted to ICU. But available data shows significant heterogeneity with several limitations and confounding factors. For example, when we compare the ICUs, I could tell you that depending on the resources, your decision tree would be very different as well. If you don't have beds to have the patients admit, then your outcome, then your obesity rates could be very much different from another ICU. But what we know for sure at the level of clinical practice is obese COVID-19 patients require higher level of clinical care, so they need specialized treatment, that's for sure. And public health measures for COVID-19 could increase populational prevalence of obesity by influencing health behavior and well-being. And finally, large-scale prospective cohort studies objectively assessing well-described outcomes are needed to better understand the association between obesity and COVID-19. So thank you for your attention.
Thank you very much. Thank you very much, Bulent. It was a great presentation and a lot of open issues, a lot of interesting aspects that you touched. There are already some questions from the floor, apart many saying that your webinar was fantastic, and these are the usual friends that show up in these situations. One is Melek asking if there is a difference in mortality rate between obese and obese patient with COVID and type 2 diabetes versus the obese with stress hyperglycemia. This point was raised already in the Manel seminar last week about the interest that there is around patients that do have increase in glucose during the admission without being diabetics previously. So do you have information, hypothesis on this?
Yeah, I mean, unfortunately, there is no direct comparative data, but what many of the experts feel that independent from whether you have a previous diagnosis of diabetes or not, inpatient hyperglycemia is adversely affecting the outcome. But the largest study, as I have shown, this Coronado study, could not prove this. So even though there's a working hypothesis that hyperglycemia of any case is very important, we really don't have any comparative data in the setting of diabetes versus stress hyperglycemia for obese patients.
Okay, so it's an issue that remains open. Manel is asking, is cytokine storm much worse in obese?
In theory, that's what people expect if we look at the pathophysiological link, because they already have dysregulated immune system. I mean, the immunometabolism is not working well. But again, from the clinical data, the most of the studies, unfortunately, have very short outcome, like the first 7 days, first 14 days. So we don't have a proper data to give answer to that. I mean, it makes sense, but clinically, I would say the question, I mean, the jury is still out.
Okay, another question concern the duration of obesity. Is duration or history of obesity is impacting some ways the outcome of the patients?
These are wonderful questions. I mean, food for thought. But remember, I told that the largest studies, the JAMA, New England, Lancet, and Nature papers, they don't even give the BMI information. So we don't have any real world data. But what we could say is, I mean, if we talk based on general obesity field, the people who have obesity from the childhood, we know that they would have higher metabolic risk. But again, in the context of COVID, there is not any clinical data I'm aware of proving or disproving this fact.
Again, Manel, want to know your opinion about bariatric surgery in the current situation in patients with comorbidities. What is your opinion?
Yeah, I mean, in fact, most of the bariatric surgeons, what I hear within the last week, especially after the publication of this guideline and from the political grounds in UK, they are supporting that even in this era, most of the surgeries should not be delayed. But I think it's very tricky. If the patient has, very significant metabolic problems, and we have nothing to do, even in this COVID era, based on this guideline the expert group provided, we could have timely surgery. But again, it's a tough decision. I think we need to assess on individual, I mean, case by case.
Okay, Mauricio is asking, what is your opinion about prescription of drugs to treat obesity? in this era of COVID. So there is limitation in exercise that you correctly mentioned. Should we, if we have, I don't know, you have to say, good drugs for obesity, should we use them more?
Well, the only drug available, I mean, with some efficiency is this GLP-1 receptor agonist, Lira. I know that, I mean, I heard at least that they have some studies going on. And from the diabetes field, at least for the doses up to 1.8, there is no worry to stop the drug, just to pay attention to the hydration level. But for obese people, I mean, we need data. I mean, we know it's not harmful. So, and we can continue on drugs in I would say, not severe cases. But for severe cases, I would definitely not give any medication. I would be cautious.
Okay, so you answered to Taner also was asking about continuing GLP-1. The use of combination insulin and GLP-1 receptor agonist in obese admitted for COVID, ECU versus non-ICU. So Lee is asking, what do you think about the combination of insulin, since insulin is the most prescribed drug for diabetic patient in hospital? What do you think about combining it with GLP-1?
Yeah, I mean, again, no data, but it makes sense to use the combination for the mild hospitalized cases in regular floor. But when it comes to ICU, again, I would use the insulin, but I would be cautious and hesitant to use the GLP-1 analog.
Okay, thank you, Bulent. Another question is more the crystal ball question that Kadia is asking. Since the study that you mentioned so far are short-term, are observational, and contrasting, I add. What is, in your opinion, would be the ideal prospective study to be done in this population setting?
Yeah, well, the ideal prospective study should observe the patients for at least for a few months, I would say, even after discharging from the hospital. And the collection of the data should be very much standardized. I mean, we didn't touch upon the issue of defining obesity in the setting of hospitalized patients, particularly in the ICU patients. I mean, due to these fluid resuscitations, in fact, this BMI itself is not very reliable. So we need better adiposity markers. So my ideal study would be using these markers, starting from the hospital and following the patients at least for a few months to see the short-term effects. And then I'm sure infectious diseases experts or investigators are already thinking or planning. We really don't know what's going to happen in the long run. So I would love to see what would happen to infected patients in a few years, considering that viruses could have several things in adipose tissue, several effects in immunometabolism, and they could even be linked to certain chronic disorders.
Okay, apart from the many friends that you have around the world saying that the presentation was wonderful, well researched, you were a great speaker and so on, nothing that we can believe, obviously. But Maxime is also asking, is there any difference between obese, overtrained persons, so people that do have an increased BMI, but also a higher muscle mass in terms of clinical observation and prognostic significance?
There must be. I mean, based on previous information, what we know is not all obese are the same. Some of them we know that are metabolically healthy. And when I'm looking into this COVID problem, I'm also thinking that the immunological system would not be the same. So I wish we could have a bioassay that we could look at the age of the immunological system independent from the BMI. and make clinical decisions based on that. So I would say some obese patients, even with a high BMI, if they are well trained, if their muscle is preserved, they might have very good outcome for any viral infection. So I think we need to ask the patients. What I wonder is the past medical history, like how many times they had this kind of viral infections. Like some of us have viral infections every year. Some of us do not have any viral infection. So an obese individual with a very healthy immunometabolism, I would say, would survive the viral infections much easier compared to the others.
Okay. Other questions around Anu is asking bariatric endoscopy instead of classic bariatric surgery can be more indicated, and Maneri is saying bariatric surgery is not particularly indicated since there are more complications post-COVID, the nutrition in the early post-surgical period. Do you want to add something about bariatric surgery, or we don't have enough data, and so we need to
by common sense, I fully agree with Manel. I mean, if this is an elective issue, I would not give any patients, I would not refer patients for bariatric surgery. So I would prefer postponing the surgery, except very extreme severe case that we cannot do anything and we're not able to postpone the surgery.
Okay, thank you, Bulent. Another question is concerning women. So is there a sexual dimorphism concerning consequences of obesity and the prognosis of the patient?
Yeah, I mean, that's my hot topic. Actually, I would love to see data on that. So apparently there is this sexual dimorphism for the phenotype. And what seems to be important is the androgen receptor. So androgen receptor seems to be working in addition to ACE2. And what I'm aware of already in the US, there are a few studies going on trying to use transdermal estrogens or antiandrogens in men to make the prognosis better in COVID patients. So yes, there is a sexual dimorphism, and we don't know yet. In fact, I would recommend my colleagues to read the papers from andrology, from our dear friend Manuele Simoni as well. So andrology field is all up, and they are looking at the androgen receptor and its role in this COVID pandemic.
Okay, so the Natia is asking the immunological alteration caused by obesity can return to normal after losing weight in the obese patients?
Very difficult question. Again, not good clinical data. But if we extrapolate from, for example, basal metabolic rate and metabolism and other features, we know that when an obese patient loses weight, he or she is never the same with an individual who was always lean. So that's an open question. I would love to see data on that. But my guess is it would not be the same with a lean individual.
Thanks. Natasha is asking which drug is the best solution for treating both diabetes and obesity, since there is this kind of synergism.
I mean, in general, if it's the general question, what is available to us is the GLP-1 receptor agonists. So, but there are several others in the pipeline that we are looking forward to the results.
Okay, Bulent. So many people asking questions at the last minute because they were shy during the talk. They were very concentrated, and now they rushed to ask. But we are running short of time, so would like you to give 2 or 3 very straightforward take-home messages to all the audience around the world today.
Yeah, I mean, for COVID, it seems that endocrinology is highly related. And for today's talk, obesity seems to be fascinating to look at the association and finding out the mechanisms. So far, I would say obesity is a risk factor, at least for individuals who are admitted to ICU. But we really need long-term studies with large sample sizes, and we need more mechanistic studies for the short and long-term effects of this virus in adiposity and immunometabolism.
Okay, Bulent, thank you very much. You were fantastic. You already introduced the webinar we will have next week by Anna Maria Formenti on vitamin D and COVID. And as you pointed out, vitamin D is linked also to obesity, to diabetes, to aging. So we are looking forward to this seminar in this fil rouge of webinars that so far has been outstanding. So on behalf of the European Society of Endocrinology, you mentioned also the statement on COVID that the European Society made, and Manel Puig was the first author, and more than the members of the society, since 7,000 people already accessed the paper, and this is in the first 3% of all papers for media attention of the same age. So more than the members alone acceded the paper. I think that this put together is a great initiative from the society. Thank you very much, and be well, everybody.